Hello, I'm Dr. Steven Strickland from Vanderbilt University Medical Center. Welcome to this educational activity on the management of a challenging subtype of acute myeloid leukemia known as secondary AML. In a few moments, I'll be joined by one of my nurse colleagues here at Vanderbilt, Ms. Brennan Sert. We will also welcome one of our patients, Mr. Jerry Heaton, to the panel and a subsequent discussion.
The following podcast is part of a certified educational activity titled The Oncology Team and Secondary AML, Conversations on New Science and Its Effect on Patient Care. Access the entire activity and complete the post-test at peerview.com/ZVS860. Downloadable slides and practice aids are also available.
But now let's turn to secondary AML, which, as I suggested earlier, can be a very challenging entity to both diagnose and treat. Secondary acute myeloid leukemia typically refers to the disease that evolves from prior myelodysplasia, such as MDS, or myeloproliferative disorders. Secondary AML can also arise after exposure to leukemogenic chemotherapy, and this is typically referred to as therapy-related AML. We'll talk a little bit more about these definitions shortly, but for now, it's important to note that secondary AML as a whole is considered to have a poor prognosis and is a high-risk disease. Historically, we have used a number of clinical factors to define risk in AML, and these definitions have included patient-related factors such as age and comorbid conditions, or even performance status, as well as disease-related factors which are related to AML biology. We also use cytogenetics and molecular aberrations present at the cellular level to assess risk status and prognosis. So for example, when we look at the treatment history of a patient with confirmed AML, the presence of an antecedent hematologic disorder, such as MDS, can help us confirm that we're dealing with a case of secondary AML. Let's now take a closer look at secondary AML as a disease subtype. We know that it's certainly less common than de novo AML. However, we also have registry data from Sweden showing that a significant minority of patients can present with secondary or therapy-related disease. And in this registry, patients who had secondary AML, whether with a preceding hematologic malignancy or therapy-related AML, had a much worse survival compared with de novo AML. We also know that the incidence of secondary AML increases with age. So in this registry from Sweden, for example, about a third of patients had either an antecedent hematologic disorder or treatment-related AML, and the rest were considered to be de novo. The incidence appears to increase with advancing age, as you might expect, in terms of the treatment-related disease and also in the result of natural history of MDS. Regardless of whether a patient has treatment-related AML or secondary AML, and is either a younger patient or an older patient, the impact on the prognosis is similar. These patients do less well even though the intensity of our therapies and therapeutic options might be different. Let's now turn to the World Health Organization classification of AML, which was modified in 2016 and describes the various subsets of secondary AML. One subset is so-called AML with myelodysplasia-related changes, or AML-MRC. Patients are considered to have AML-MRC if they have a history of MDS or MDS-MPN overlap syndromes, including CMML, atypical CML, or RARST, a myelodysplasia-related cytogenetic abnormality. At least 50% of cells in 2 or more myeloid lineages are dysplastic, except if NPM1 or biallelic CEBPA mutations are present. As I've noted, there are some cytogenetic abnormalities that are diagnostic of AML-MRC, which can be seen in this slide, and they include the presence of complex karyotype, among many others. These can confirm a diagnosis of AML-MRC if at least 20% peripheral blood or bone marrow blasts are present and the prior therapy has been excluded. And what about therapy-related AML? It accounts for about 10% of patients with AML overall, and generally we understand that it can be triggered by exposure to certain chemotherapies, including alkylating agents as well as anthracyclines. In general, there's a longer latency period for patients who are exposed to alkylating agents such as cyclophosphamide, something on the order of 10 years. But there's no lower limit or upper limit on how we define the association. On the other hand, patients with therapy-related disease exposed to anthracyclines, anthracene diones, or other topo-2 inhibitors typically present with AML without preceding MDS and with a much shorter latency on the order of 1 to 3 years. Let's move on and discuss the treatment options for secondary AML. For many years, the standard cytarabine-based chemotherapy that has been the standard of care in AML was of limited efficacy in higher risk settings such as secondary AML. We've recently seen evidence that has validated several newer treatment options including novel co-formulation of cytarabine and daunorubicin, as well as the BCL2 inhibitor Vanetta in older patients with secondary AML or unfavorable cytogenetic risk factors, respectively. We'll discuss CPX-351 in more detail shortly, but here you can see that these options have been included in the most recent NCCN guidelines in this area. When we turn to adult patients with AML who are under 60 years of age, we also see that CPX has been included in the guidelines as an option in the management of secondary AML along with standard dose cytarabine therapy. What about the evidence supporting the use of these options in secondary AML? Let's briefly explore some of the data in this area, starting with CPX-351. This agent was approved in 2017 for the treatment of AML in adults with newly diagnosed therapy-related AML or AML with myelodysplasia-related changes. It is a liposomal formulation of cytarabine and daunorubicin with a 5:1 fixed molar ratio, and this packaging seems to provide synergistic and enhanced cytotoxicity against the leukemic cells. The drug ratio appears to be maintained for about 24 hours, and even though it's given as a shorter interval infusion on days 1, 3, and 5, there seems to be persistence beyond the timing of administration. In one sense, it mimics the exposure that we strive for with the continuous infusion cytarabine without having to keep patients hooked up to the IV the entire time. Early phase 2 evidence showed that CPX-351 improved 60-day mortality, the remission rate, as well as the overall survival compared with 7 and 3 chemotherapy in patients with newly diagnosed secondary AML. This led to the development of a large phase 3 study in older patients with high-risk disease. And in this phase 3 trial, CPX was tested against 7+3 in patients aged 60 to 75. This patient population was previously untreated and was eligible to receive intensive therapy. These results are now published, and as you can see here, the use of CPX-351 improved the overall survival among this high-risk AML patient population, with the median overall survival of 9.56 months compared to 5.95 months with the 7+3 population. CPX-351 was also associated with improved event-free survival. In this study, the overall remission rate was also significantly higher with CPX-351 versus 7+3 at 47.7% versus 33.3% respectively. In general, improved outcomes were also observed across age groups and among AML subtypes. The use of CPX-351 also allowed more patients, regardless of age group, to receive subsequent stem cell transplantation. In other words, more patients treated with CPX induction were able to proceed to a potentially curative transplant. This is relevant because, as we can see here, the median survival since transplant of patients who received CPX was not reached compared with approximately 10 months for the 7+3 arm. Evidence from this study also showed that in a subset of patients specifically described as having therapy-related AML, a substantial benefit was shown in patients treated with CPX-351. When we look at safety, the rates of adverse events were similar with CPX-351 and standard chemotherapy, although the researchers did note prolonged time to neutrophil and platelet count recovery with the newer agent. But this did not translate into greater mortality, as early mortality rates with CPX-351 and 7+3 were 5.9% and 10.6% through day 30, and 13.7% and 21.2% through day 60, respectively. We'll discuss safety consideration with CPX in more detail in the next segment. Now let's move on to discuss some earlier evidence of hypomethylating agents in secondary AML. As we've seen from the NCCN guidelines, the use of hypomethylating agents can be considered an option in the poor prognosis disease. And in practice, these agents, including azacitidine and decitabine, are used to treat patients with secondary AML. One major trial that tested this concept was the AML 001 study, which assessed patients over the age of 65 with newly diagnosed de novo or secondary AML with adequate performance status and intermediate or poor risk cytogenetics compared with intensive chemotherapy. Low-dose cytarabine, or best supportive care, so-called conventional care regimens. Although in the overall population there was only a trend for improved survival, the researchers did note that azacitidine appeared to improve outcomes in patients with AML-MRC as well as in patients with poor risk features. There are other recently approved agents that have potential applications in secondary AML, including the BCL2 inhibitor Vanetta, which inhibits the anti-apoptotic protein BCL2 and promotes apoptosis of malignant cells. Vanetta is included in the NCCN guidelines as an option in unfavorable risk AML, as we saw earlier, and is FDA approved in combination with either azacitidine or decitabine or low-dose cytarabine for the treatment of newly diagnosed AML in adults who are aged 75 years or older or who are unable to receive intensive chemotherapy. We also have some recent evidence with venetoclax in secondary AML. In one study of previously untreated older patients deemed unfit for intensive chemotherapy, including many patients with secondary AML, the combination of venetoclax with low-dose cytarabine appeared to be highly active, with an overall response of 54% and a CR rate of 26%. In the subset of patients with secondary AML, the overall response was 35%. MRD negativity was seen in 32% of patients who achieved a CR or CR with incomplete count recovery. The median overall survival was 10.1 months overall and was not reached in patients achieving a complete remission. Venetoclax has also been associated with some unique adverse events, including tumor lysis syndrome, which we'll discuss in greater detail in the next segment. And welcome back. In this segment, we'll discuss several practical issues that are important to consider when managing patients with secondary AML. I'm pleased to welcome my nurse colleague from Vanderbilt, Brennan Surt, to the panel. Welcome, Brennan.
Thanks. I'm looking forward to our discussion.
Why don't we start by talking about a diagnosis of secondary AML. I'm thinking about a patient struggling with a recent diagnosis after a long bout with prior MDS, someone who's older, maybe 75, 76 years of age, someone who's lived an active lifestyle despite this MDS diagnosis that they've carried for 8 years, but now who's struggling after hearing the news that he's developed secondary AML. How might you counsel this kind of patient given the advanced age? What kind of therapy might you discuss with them?
So that's a great question. Before we get to that scenario, I'd like to share some of the general diagnostic steps that we review with AML patients before we start their treatment. So the first thing I like to do is get a really good history and physical assessment on the patient and kind of figure out what their quality of life is. After I get some good general information, we do blood work such as a CBC and coagulation testing to get a good baseline for the patient. After that, we'll perform a bone marrow biopsy to decide exactly what the plan is for the patient. The team can talk about it. And then if the patient ends up being a candidate for transplant, we'll also do HLA typing and go ahead and start that process. First and foremost, we like to be honest with our patients. We like to let them know that patients with AML, it's a hard-to-treat, challenging disease, and secondary AML is certainly hard to treat, but the good news is that we have options, including newly approved agents. So we like to talk about those with them and their family together. Families are important extensions of care and a big part of support groups. We also like to talk about quality of life with our older patients. Quality of life is different for every patient, and so we like to discuss what exactly their quality of life is. I like for them to describe what is a good life for them and what they expect to be able to do. If the patient has a good functional performance status, they could potentially benefit from intensive treatment. We like to prepare to discuss currently available options and remember that under-treatment is a concern.
Thank you, Brennan. And it's very interesting dealing with these patients. I also think it's useful to educate patients on the role that bone marrow dysfunction plays in the disease. We often have to discuss with the patients if it's MDS-related AML, the background bone marrow dysfunction sets the stage for AML to develop in the first place. Even if chemotherapy induces remission, that background dysfunction, unfortunately, still sets the stage for their recurrence and or eventual relapse. And that's one reason that we use bone marrow transplant to offer them the potential hope of a cure. And we know that exposure to prior chemotherapy for other malignancies that may have rid them of their prior malignancy, but at the same time unintentionally induce some type of bone marrow damage and set the stage for this leukemia to develop in the first place. But before we get to some of the more practical information, let's first discuss a case in regards to a patient named John, an older patient, fit patient with newly diagnosed secondary AML who wants to pursue aggressive therapy. He's 70 years old, presents with a diagnosis of secondary AML after a long battle with myelodysplastic syndrome, but he has a good performance status. We first get the bone marrow biopsy results, and in going over them, there's evidence of dysplasia, evidence of the cytogenetic changes that would be typical chromosome 5, chromosome 7 abnormalities, and some of the high-risk molecular abnormalities. And we have to discuss these with the patient and inform them of what the prognosis is, and just that, unfortunately, while we have chemotherapy that has a reasonable chance to get him in remission with standard induction therapy, it does require often a prolonged hospital stay. Agents such as CPX-351 are an option for this patient, and potentially in conjunction with a transplant if we're going to consider the possibility of potentially curative therapy in the future. John, wants to be aggressive, but he's not sure that he's really a transplant candidate because of his age. But after going through the therapy and achieving remission with a good functional status, and provided we're able to identify a donor, it often takes a lot of explanation of educating patients about transplant and helping them to realize that may be a realistic option. So Brenna, what kind of tools do you typically use once a treatment plan has been developed and the patient is preparing to receive therapy?
There are a lot of different resources that we use with new diagnosed patients or with different types of cancer later on. One of the things that I like to use is a calendar made specifically for that patient's chemo regimen. So after the team decides this is what we're going to use, I like to physically write out which day is going to be which treatment. So that way the patient can kind of follow along exactly what's going to happen every day and there's no surprises.
I think it's interesting as well that, with that calendar, there's the chemotherapy exposure up front, but then there's a long recovery time that patients have to be aware of, and I think that gives them a visual representation so that they realize their hospital admission often doesn't end just with the completion of the chemotherapy admission, and that this is sort of a prolonged process that they have to be prepared for.
I like to add that there's not always an exact day that their counts recover, and so I like to make that section a little bit longer so that if they hit day 14 and they haven't recovered yet, they don't get nervous, that sometimes it just takes a little bit longer for each person, and sometimes it's a little bit quicker, so I like to give them a realistic visual of what could happen.
I think that's very helpful. So what about patients with prior experience of chemotherapy for other malignancies such as breast cancer or lymphomas, patients who present with therapy-related AML? How do you counsel these patients?
The first thing I like to talk about is what kind of chemotherapy they got the first time. Usually patients have a lot of questions. Is it going to be the same chemo? Is it going to be different? What are the side effects of the new ones going to be? And once the team has decided exactly what treatment we're going to use, I can actually print out and make like an information sheet to talk about exactly which chemotherapy it's going to be, see if they're having some of the same side effects as decided, exactly therapies, and just kind of educate them on the differences between the two different types of treatment. Another issue that we like to speak to patients about is drug administration. So we have oral chemos and we have IV chemos. And if they're going to get IV chemotherapy, typically we have to have some sort of central line, whether it be a CVC or a PIC. If they've gotten chemotherapy before, they know this, and they've had one before, or they could be getting a different one. So we would have to do education on exactly what type of central line they're going to have. And obviously the people that are inserting these things will tell them the risks and things like that. But we like to educate our patients on infection risk and exactly how to take care of it. Most of our patients go home with central lines, as you know. And we have to teach them how to flush it every day and how to keep it clean and that they can't get it wet and exactly how many pounds they can lift with that arm if it's in the arm versus the chest. And typical things like that, that's going to change their everyday activities. And we have to educate them on and make sure that they know exactly what they're dealing with.
Thank you very much for that. And let's move on and talk about some of the agents that we use to treat secondary AML. What can you tell us about your approach when educating patients who are about to get CPX 351?
So like I said, the first thing I start off with is the calendar. So for this one, we would actually start the induction and it would be on chemo days 1, 3, and 5. And then if they were to need another boost of induction, we could do it on days 1 and 3. And then for the consolidation, we would also do it on chemo days 1 and 3. I'll also discuss some of the safety considerations, including some of the events seen in phase 3, which were febrile neutropenia, fatigue, pneumonia, hypoxia, hypertension, bacteremia and sepsis, respiratory failure, and then a decreased ejection fraction. One of the differences that we see with CPX 351 is that it can induce delays in count recovery, but we also have experience in addressing this complication. We also like to counsel our patients on neutropenia, which would mean that their ANC is less than 500 to 1,000. We like to counsel them on different infection risks because it's much easier for them to get an infection. This also puts them at risk for needing blood transfusions, platelets, and red blood cells. We talk about those thresholds and the fact that they might need those transfusions every day for a little while, or they might not need them except for a couple times a week. When they're inpatient, we typically look at their blood counts at least one time a day, if not a couple times a day. And then when they're in the clinic, we'll check them 2 to 3 times a week.
So let's turn our attention now to one of the oral therapies, venetoclax. Brennan, what are your thoughts on issues such as tumor lysis syndrome and other adverse events that we've seen with our experience with venetoclax and our patients with AML, including secondary AML?
So monitoring for neutropenia is recommended for the patients with AML on treatment with venetoclax. And we need to educate our patients for potential for TLS. Typically, patients with TLS would be admitted inpatient, and we would check their blood levels every 6 hours or so. We like to make sure that they have adequate hydration, not only with IV, but we like to educate them for actually taking oral intake. And then we can give them medications that help reverse these things. And so we have to educate them on all of those, like lowering their potassium and things like that.
I think one other thing too is that we try to remember to start some of these therapies like the anti-hyperuricemics even before we're initiating the chemo to try and prevent hopefully the complications of TLS or begin to manage it even before it occurs.
Venetoclax is an oral agent, and there are a number of steps we can take to make sure patients experience the full benefits of the therapy. We usually start the dosing schedule at 100 milligrams, and every single day we bump it up to their goal range, whether it be 400 or 600 milligrams. We like to do this over a period of time, and then we'll follow up with these patients, whether they're inpatient or outpatient. We need to educate them on potential drug-drug interactions, like with CYP3A inhibitors. And we have to educate them on things like taking this medication with food and helping with the absorption of the medication.
Yeah, I do think it's important too to remind them that it's something they should take every day and trying to take, nearly at the same time every day if they can within some reasonable amount. And I think it's also important for providers to remember that the target dose is not the same. It does depend on which partner in combination that the venetoclax is being used with, whether it be with the hypomethylating agents and it caps out at 400, or if given with low-dose cytarabine, if they're going to go as high as 600 milligrams.
Some other lower intensity therapies that can be used in this setting include decitabine and azacitidine, and these HMAs also have some safety considerations that we have to be prepared to talk with our patients about. Both of them can cause anemia, neutropenia, thrombocytopenia, so we monitor their CBCs really closely. They can also both cause embryo-fetal toxicity, so we need to counsel patients on the reproductive risks, especially if they're a little bit younger. That can be an issue. In azacitidine, we monitor for hepatotoxicity, renal toxicity, and TLS.
Thank you very much for that and for providing all those practical points that we need to remember. Now we're going to welcome a patient to the panel and hear about one person's journey with secondary AML, so don't go away. And welcome back. And it's my pleasure to welcome one of my patients, Jerry Heaton, to our panel and to share his story and perspectives on his care. Jerry, welcome.
Thank you. I'm glad to be here.
So let's get started by reviewing some of your prior history with cancer.
Well, back in 1985, I was diagnosed with Hodgkin's disease. I took a year of chemotherapy. I had 12 radiation treatments, and I'd done that for a year and got in remission with that. And now, 30 years later, here I am with AML. It was surprised me, but then again, I just said, well, here we go again. The treatment I got and everybody explaining everything to me, everything worked out. I was glad to meet Dr. Strickland and Brennan and everybody there. They treated me good. There was no way I could have been treated no better. And my wife, she took care of me for a long time. You can't beat Vanderbilt. I'll just tell you, they really took care of me.
So Jerry, I remember that when you were transferred to Vanderbilt, we determined even though that some of your records were lost because it had been such a significant time lapse between you when you were originally diagnosed with Hodgkin and treated and then presented to us, that you had been treated with ABVD, regimen typically used for Hodgkin lymphoma, along with radiation therapy. And that gave us some additional information and when we decided on your treatment for your AML. But Before we get to that, can you tell us what kind of symptoms you were experiencing before you were diagnosed with leukemia in 2017?
Mostly I was experiencing fatigue. I stayed very tired. I was trying to work. At the end of the day, I was just about gone. I mean, I was just a lot of fatigue, and that's mostly what I had experienced.
And I think that's often pretty typical for a lot of our patients. The presentation can be very non-specific, and they just feel tired, and they think it's, well, I'm getting older, or something, I had a cold, or I've been under a lot of stress, or they often explain it away by a lot of other things and come to find out that there's something like leukemia that's driving this and causing those symptoms. So at that time in December of 2017, we had then a recently approved drug with CPX-351 as an option for patients with secondary AML. And we talked about how it might be best for you, and along with the potential, ultimately, a stem cell transplant. So what do you remember about, and what was your experience when you were on therapy?
Compared to what it was years ago, it was pretty easy. I mean, to me, compared to the old chemotherapy. And I had a little bit of nausea. Otherwise I didn't have a lot of symptoms, just didn't eat a lot and losing your appetite. And mostly that's all I really experienced through it.
And I think that, it's interesting because some patients can actually, tolerate this formulation of the medicine sometimes better than they do the others. We know that you had a prolonged hospital stay, and we know that it can take more time for the counts to recover, and we do see that quite often in patients with this regimen. But again, getting back to that long hospital stay, as you know, we often keep patients after they're getting their induction therapy in the hospital for a long time, and rather than making them get lodging near the hospital or make numerous trips back and forth every day, many times patients can be there for an extended period of time, as you were. So, we recommended at that time that you receive a stem cell transplant once we had it in remission, and once we were able to achieve the desired response with the CPX-351. So if you can go back to that time, what were you thinking when we started to use the terms like transplant, and just kind of, can you tell us what was going through your mind?
Yeah, well, I didn't know a whole lot about stem cell, and it was new to me at the time. But the people at Vanderbilt, they were very helpful and explained everything to me and made it quite easy. I stayed in like 60 days. Everything went good. I mean, everything was clear to me. They explained everything to me.
So Brennan, Jerry raises some interesting points about transplant, and what are some educational approaches that we typically use here at VUMC to counsel our patients about this procedure, and how does it differ from some other of the AML disease state education that we might offer?
We like to educate the patient on the timing of the procedure. So after chemotherapy and they've achieved remission, that's when we like to talk about possible transplant. They would need something called a CVC, which would be in their chest. That's what the transplant, the stem cells, would go through. And that's one of the procedures that we like to educate our patients on with detail, so that they know exactly what's going to happen that day, and that there's no surprises. There's all different types of conditioning regimens, and the team would pick those, and then we would educate on those appropriately. During the stem cell infusion, we like to kind of warn the patient exactly what could happen. So they might have symptoms such as weakness or fatigue. A lot of them have a flushing feeling and get kind of a red face. They can also get fever and chills, and occasionally some chest pain. So we like to make sure that we always have these patients on the monitor, and that there's a nurse in the room at all times. There's a nurse practitioner in there for most of the time, and we're constantly monitoring these patients with their vital signs every 15 minutes and things like that. And then after the transplant is done, we like to educate our patients on the symptoms of GVHD and VOD and infection, so that they know exactly what to report to us if it's something that we can't see in a test.
Thank you, Brennan. So Jerry, is there anything that you'd like to say to any patients out there who might be facing a similar diagnosis of secondary AML, or who might be preparing to start treatment for their disease?
Well, the only thing I would know, just to tell them that there is hope. You know, if they get to where they think there's no hope, there is hope. And the best thing happened to me was running into you all and you treated me. I mean, it's saved my life. In the long term, you're going to experience some fatigue, and it lasted 6 months or maybe even longer. But it's worth it. It's well worth it.
I think that's one of the interesting things too is, you know, we talk about the diagnosis and we talk about the treatment and hopefully achieving remission and then getting to a transplant. And it seems like it's often thought about every time we get to a finish line, when in reality it's just a new starting line. And after the transplant, experiencing that fatigue and dealing with all of the things of the recovery portion, it does take time, and people need to be prepared, I think, for that long haul that goes along with it. So thank you again for sharing your story and for joining us today, and really happy to see you again.
Thanks for inviting me, and I really enjoyed it.
So Brennan, thank you as well. I appreciate your participation in the panel.
It was great, thanks.
Thank you all for joining us today. I hope that you found this discussion educational and useful for your practice.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/ZVS860. This activity is supported by an educational grant from Jazz Pharmaceuticals Incorporated. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.